Hello, my name is Jamie Newsom. Today I will present a case study involving a 34-year-old male diagnosed with generalized anxiety disorder, DSM F41.1. I will review his medical history, diagnostic rationale, mental status examination findings, and cognitive behavioral therapy treatment plan grounded in Beck's cognitive model. The patient's chief complaint is, I need someone to write my medications. He is 34-year-old male with a history of generalized anxiety. Symptoms started about 2 years ago. His stepfather passed, and he initially began to have anxiety symptoms. He has been in therapy for 2 years, which he states is beneficial. However, he reports increased anxiety and sleep disturbances. He reports he worries over everything. Currently, he is prescribed Paxil 10 mg by mouth daily and hydroxyzine 25 mg by mouth at night as needed for anxiety and insomnia. Anxiety symptoms currently disrupt daily routines both at home and in the workplace. Family history shows prominent anxiety with his mother. He is married with 2 children and reports strong family support. He is employed by American Electric Power. He mentions that his anxiety has begun to affect his job performance and reports difficulty concentrating. I will now discuss criteria ruling in the patient's diagnosis. This patient meets the DSM-5 criteria for generalized anxiety disorder. He experiences excessive worry on most days for over 6 months and struggles to control this worry. He reports symptoms including restlessness, fatigue, irritability, muscle tension, and sleep problems. These symptoms interfere with his daily functioning and are not caused by substances or other medical conditions. I ruled out diagnosis of panic disorder, obsessive compulsive disorder, post-traumatic stress disorder, depression, and bereavement-related adjustment disorder. There are no reports of hallucinations, delusions, mania, hopelessness, anhedonia, or suicidal or homicidal ideation. Furthermore, no substance use or medical conditions are contributing to the presenting symptoms. The symptoms are extensive and persistent, and although they were first noted after the death of his stepfather 2 years ago, current symptoms are not linked to any specific event and are more generalized, including work, home life, and general finances. During the interview, the patient appeared well-groomed, alert, and cooperative. Eye contact was appropriate and engaged. No mannerisms were observed. Speech was relaxed with an appropriate rate and rhythm. Memory, both recent and remote, was intact. Affect was mildly anxious but appropriate. Thought processes were logical, goal-directed, and grounded in reality. Insight and judgment were intact. No safety concerns were noted. The main non-pharmacological treatment approach is cognitive behavioral therapy. Focus areas include addressing ongoing worry, exploring the links between thoughts and emotions, and restructuring negative thought patterns. Daily worry journaling will increase awareness and support cognitive reframing, identifying individual common catastrophizing themes, using mindfulness to mitigate anxiety triggers. Exposure-based strategies help decrease avoidance behaviors. Relaxation techniques such as deep breathing and progressive muscle relaxation lessen physiological arousal and support emotional regulation. CBT is based on Aaron Beck's theory that automatic thoughts and core beliefs shape emotions and behaviors. Anxiety comes from distortions like catastrophizing or overgeneralizing. Therapy helps modify these patterns to reduce symptoms. According to Beck's model, The patient has negative perceptions of self, the world, and the future. The treatment plan involves addressing beliefs such as, I can't control my stress, and things will never improve. Challenging these perceptions and assessing their validity helps to rationalize negative thinking. The intervention focuses on using mindfulness, cognitive restructuring, and behavioral activation. Interventions include cognitive behavioral therapy, mindful exercises, grounding techniques, breath awareness, and sleep hygiene strategies. The aim is to lower anxiety levels and enhance sleep quality by developing consistent sleep habits. General instructions with a patient cover medication, side effects, and education. Paxil may cause weight gain, sedation, sexual dysfunction, and gastrointestinal changes. Hydroxyzine can cause sedation, dry mouth, and in rare cases, QT prolongation, which can lead to arrhythmia. Labs include LFTs. Paxil is metabolized by the liver and renally eliminated. Metabolites eliminated renally are mostly inactive. Syndrome of inappropriate antidiuretic hormone secretion can be seen in SSRIs such as Paxil. Monitoring serum sodium will need to be part of the treatment plan. Education on symptoms to monitor such as headache, fatigue, nausea, vomiting, muscle cramps, and feeling foggy-headed or dizzy. Paxil was increased to 1.5 tablets, 15 milligram daily for worsening anxiety. He had been on 20 milligram in the past, but it caused problematic sedation. Hydroxyzine was continued at night as needed for anxiety and insomnia. He was educated on worsening symptoms that included suicidal or homicidal ideation, and was instructed to contact the provider's office or contact 911. Also, he was given the crisis hotline number. The objectives include increasing sleep to 6 hours per night and reducing anxiety levels by 50% within 6 weeks. Progress will be tracked using GAD-7 scores, aiming to lower the score from 8 to 5. Improved coping skills and stress resilience are expected outcomes. This concludes my case presentation. Thank you for listening.